The prostate is an organ that sits in the base of the bladder in men. Its function is to add components to the semen to increase the chance of a sperm fertilizing an ovum. But with increasing age, the prostate changes. And there are alterations in the way the prostate is made up with different amounts of fibrous and muscular tissue. And this increase in size and increase in fibromuscular tissue is known as benign prostatic hyperplasia, or BPH. You tend to find that the first evidence of BPH is present in men at about 40 years of age and increases in size beyond that. And the approximate increase in size is about 10% every 5 years. What this means is that by the age of about 80 years old, about 80% of men will have evidence of BPH, benign prostatic hyperplasia. The prostate surrounds the urethra sitting at the base of the bladder and can inhibit free passage of the urine through the urethra. It does this essentially in two ways. Firstly, as the prostate increases in size, it can abut on the urethra and occlude the urethra. This is called the static component of obstruction. There is also, in addition, a dynamic component of this obstruction, in that the prostate is full of fibrous tissue, but also muscular tissue. And this muscular tissue can contract and compress the urethra and squeeze it shut. These two components often work together such that they inhibit the free passage of the urine along the urethra. This will manifest itself in symptoms such as a poor flow of urine, a intermittency of passage of urine, and a hesitancy and difficulty starting to pass urine. There is another effect that benign prostatic hyperplasia can have, in that by obstructing the bladder has to increase its pressure in order to overcome the obstructing prostate. What happens as a result of this is the bladder can become hyperactive and unstable. This will manifest itself in urinary symptoms of urinary frequency, urinary urgency, and nocturia, in other words, getting up 3 or 4 times at night to pass urine. Benign prostatic hyperplasia, or BPH, may require no treatment at all, and really the treatment depends upon the presence of troublesome urinary symptoms. The first step in management may be simple as lifestyle changes, cutting down the amount of fluid you drink before you go to bed, cutting down the amount of fluid you drink before long car journeys, or maybe cutting down the amount of caffeine and coffee you drink, which can affect the bladder symptoms. The next step would be medication in the form of tablets. There are 2 main types of tablets that are offered for symptomatic BPH. Firstly, there's the alpha blocker. The alpha blocker, such as tamsulosin, inhibits the contraction of the smooth muscle within the prostate. This has an effect on the dynamic component of obstruction and may relieve some of the symptoms of obstruction. There is a second medication, the so-called 5-alpha reductase inhibitors, such as finasteride. This has an effect on the static component of obstruction. What 5-alpha reductase inhibitors do is they cause shrinkage of the prostate and relief of the static obstruction. It's important to be aware that this occurs via shrinkage of the prostate, which may take 3 to 6 months to have its effect. So the effect of 5-alpha reductase inhibitor medication isn't overnight and may take a number of weeks before symptomatic improvement is seen. One of the problems with both these medications are that they have side effects, and some patients don't like to be on these medications due to these side effects. In a proportion of patients, further treatment may be required. We're fortunate at the moment there are a number of different options that can be tried. Firstly, prostatic artery embolization. This is a procedure that's done in the radiology department where small pellets are placed by the radiologist into the arteries supplying the prostate, which cause the prostate to shrink. This is done under local anaesthetic as an outpatient procedure. The second treatment option is called urolift. This is done by urologists. It can be done under local anaesthetic or general anaesthetic. It involves inserting a tube up the urethra and using staples to staple the prostate open. The third and one of the newer forms of treatment is called Resume. Again, this is done by a urologist under local anaesthetic or general anaesthetic, often as an outpatient or day case procedure, and it involves a telescope being inserted up the urethra to the prostate and using a tiny needle to inject steam into the prostate. What that steam does is cause the prostatic cells to die, and the prostate involutes and allows opening of the prostate and improving voiding. One of the issues with this is that a patient would need to have a catheter following this procedure for 2 to 5 days while the inflammation in the prostate settles. The advantage of all three of those treatments are that they are minimally invasive and can often be done as a day case or under local anaesthetic. However, there are cases where a more complete resection of the prostate is required. The standard way this is done is using electricity, the so-called transurethral resection of prostate, or TURP. This again is done by a urologist under general anaesthetic. It requires a 2-night stay in hospital. With the advent and development of lasers, in my view, the TURP has been improved upon, and now lasers are used to do the same procedure. The standard one that I would use is called a holmium laser enucleation of the prostate, or HOLEP. This again is done by urologists under general anaesthetic as an inpatient. Although some patients can go home on the same day, the majority are kept in overnight with a 1-night stay in hospital. The HOLEP is my chosen technique over and above TURP. I think it is an improvement on TURP because it does a more complete resection. There is less bleeding, and in the majority of patients, patients can get home after 1 night stay in hospital. It's not possible to say what is the best treatment for BPH, as this will differ from patient to patient. If treatment is required, we're in the very fortunate time where a number of different options are involved, which all have advantages and disadvantages. It's absolutely crucial that a patient is referred to a urologist to discuss these options. The question will be what of the options that are available is best for an individual patient, and this will depend on a number of factors, such as the size of the prostate, the shape of the prostate, the general health and comorbidity of the patient, and of course the patient's wishes and desires. I think what is absolutely crucial in this day and age, that patients get the opportunity to speak to a urologist who is knowledgeable about the full range of treatment options and is able to fully discuss these options in an open and honest way with the patient and with clinical equipoise. In addition, it's important that the urologist should be able to provide all these different treatments or have the ability to refer the patient on to another clinician who is able to provide the treatment option that he or she is not able to provide.